Greetings, everyone. I was going to say good morning, but good morning, good afternoon, good evening for those joining us from all over the world. Welcome to this alumni panel for the 10th anniversary of the MMSc-GHD program. I'm going to stop sharing that slideshow right now. This is the final in our series of panels for this year. This 2022 marks the 10th anniversary of our master's program. And to celebrate, we've been having panels every month. So we've had a bunch of these panels. They've been really great, inviting alumni back to talk about their experiences after the program and the work that they have done. So today we're so excited to have 3 alumni, and I'm going to let Joya introduce them. But what I want to do is just let people know, in case you're not familiar, the MMSc-GHD program, the Master of Medical Sciences and Global Health Delivery, is a 2-year program that is focused on improving healthcare delivery across the world with a focus on equity. And so our alumni have done work on that, and we're excited to hear about their work. If you're interested in the program, we will send a follow-up email to everybody who's registered with our program website. And then, as I mentioned earlier, but want to mention again, we will include in that email a link for our thesis presentations, which are next week for the class of 2023. So very exciting. And those will be broadcast on Zoom, and you're welcome to join for any part of them. So for now, what I'll do is say welcome and thanks for joining us. And Joya, do you want me to see? I don't know if are you ready?
No, I'm fine. Yeah, I'm ready.
Yeah,
I'm ready.
Okay, great.
Yes. So thank you all, as Christina said, for joining us. I'm just about to sit down. I was on the train. And, you know, to me, health systems is one of the critical reasons that we launched this program, because before the year 2002, many impoverished settings around the world didn't have health systems at all. They had very rudimentary public health systems to do prevention, but without treatment. And there were no labs, there were no x-rays, there was insufficient staff. And as we sometimes say, not enough staff, space, systems, or social support to really make healthcare a right for people as it ought to be. And so a lot of the focus of the Masters in Global Health Delivery program is to actually deliver care, comprehensive care, not just prevention, not just treatment, but all of those things. And at the community level, at the health center level, at the hospital level. So to me, it's very fitting that this last seminar is on health system strengthening with 3 of our amazing graduates. And can I just say that we are just so proud of this program. I have learned so much from all of the students and graduates that have gone through. People have taken on remarkable roles across many countries. You know, Zarni Htun is now working for Médecins du Monde in India. He was a Fulbright scholar in our program from Myanmar, now working in India on harm reduction. Dr. Htun was running the Clinton Health Access Initiative in Myanmar. Dr. Evrard Nahimana, who was our regional chief of policy and partnerships across Africa at Partners in Health, but now has taken a job as the chief of party on a very large multi-million-dollar World Bank project in Sierra Leone. And Dr. Jafet Arrieta, who has been working for the Institute for Healthcare Improvement in many countries. You know, I say, well, here's Jafet in Lesotho, and here's Jafet in the US, and here's Jafet in Mexico. And so these skills of how to understand health systems through really a biosocial lens has proven to be a fantastic and unique skill set for all of our graduates. And we're just excited to hear what they're up to now and what they're doing. So I think, is Zarni first?
Yes, thanks so much, Joya. Okay. I forgot to mention the structure. I'll just note that, and then we'll have Zarni start. Just so all the participants know, we'll have the 3 speakers, each speak for 10 minutes, Zarni, then Evrard, then Jafet, and then we will have questions. And the way we'll take questions is please type them in the Q&A. You'll see at the bottom of the screen, there's a Q&A. And once we get to that point, we will respond to the questions. The panelists will respond to the questions, and then also Joya will lead discussion. So Zarni, we're going to start with you, and I will share your slides. And so just be sure to tell me when you want the next slide.
All right. So thanks a lot to everyone. So good morning again to you, Joa, Christina, my fellow panelists and colleagues. So I'm going to talk about how health systems perform and respond in times of crisis and the role of key stakeholders, especially non-state actors in the case of Myanmar. Yes, next please. So before I present, it will not be about a particular project or a program. It is not about scientific work or study, but today I'm going to share with you my lived experience and learnings when Myanmar is facing crises like the COVID-19 pandemic over the last few years. Next. So first, let me share you a recap on my MMSc-GHD thesis. So it's examined the role of Global Fund financing on the national HIV/AIDS response. So can you just click so that it will pop up another item on the screen? Yes, so it was a mixed method study. I used the WHO Health System Strengthening Framework for analysis, and I applied the concept to different analytical models. Click. So I understood that understanding the context was important. So I decided to use the biosocial lens to gather my findings, and that involved the analysis of the resocializing disciplines. Just a click. So I gathered the findings into the evidence, formulated them into policies, and proposed recommendations. Right. Next, please. So I compiled the finding into a specific model that analyzed the context, health system pillars, the population, and the health outcomes, and put forward the recommendation as you see them on the screen. Next, please. So giving you an overview, a quick overview, Myanmar is a country with high burden of diseases and poor health outcomes. And there are also chronic health system issue and disparity in access to health services. Myanmar is also known for relatively low health spending and high out-of-pocket payments for health services. On top of these, there are additional triple burden. The first one was the impact of the COVID-19 pandemic. The second one was the military takeover of power in February 2021. Both the COVID-19 and the coup triggered socioeconomic consequences. And these triple burden have a negative impact on the health system. Next, please. So giving you a quick overview of how COVID-19 situations looked like. So the first two confirmed cases were reported in March 2020. And by the end of 2022, there were over 600,000 confirmed cases. The majority of those cases belong to the 3-meter epidemic waves, as you see them on the screen. Next, please. So the authorities and the Ministry of Health, MOH, introduced several directives and orders, like the travel restriction, lockdowns, and stay-at-home orders, night curfews, etc. Next, please. So now you can imagine how Myanmar had to struggle with the pandemic. Let me explain you briefly about the most critical issues and challenges we faced, beside many others. Next. So as you may know, we have hundreds of thousands of unskilled laborers from Myanmar working in the neighboring countries. With the shutdown of business and factories in those countries, many of them returned home. There were many returnees coming back across both the eastern and the western borders of the country, and of course, via relief flights. So the country struggled with resource constraints to host all of them back in a mass. Next, please. So we also faced the resource constraints. You just click. Yeah. And the first one was not having adequate testing capacity, despite the MOH huge effort to scale it up. Next. Another challenge was not having adequate quarantine facilities. MOH allowed opening of the community quarantine sites and later adopted the policy for home-based quarantines. Next. Myanmar did not have enough infrastructures to host all the COVID-19 patients. Hospital beds were full. Most patients, even with critical illness, had to stay home. Next, please. On top of those situations, there were another critical problem affecting the health workforce. Following the military takeover, many civilians went for protest against the regime. As part of the countrywide civil resistance, many health workers of significant numbers joined the civil disobedience movements called CDMs and left the jurisdiction expressing their disapproval of the regime. Next, please. Access to oxygen was a huge challenge for many people. It was not a live or die issue for many patients. On the ground, family run after the oxygen tanks so that they could give the loved one access to therapy, oxygen therapy at home. Unfortunately, this crucial need was not fully met and took the lives of many away. Next, please. So let me go on talking about the role of different stakeholders in overcoming those situations. So different stakeholders play different roles. Both the public and private sectors were involved. Donors, they raised several different funding mechanisms. I must acknowledge the important stewardship of MOH and government agencies in planning and coordination. UN agencies and INGOs contributed a lot to support the health system. Next, please. So globally, we know that the important role of the MOH and health, the public sector in the pandemic response. But today, I would highlight the role of non-state actors. I think their contributions were not often highlighted enough as they absorb the burden and vital demands of the health system. Next, please. So the private sector, the corporate foundations and private companies established quarantine facilities and treatment centers in big cities. Next. To some extent, this public-private partnerships uplifted the burden on the public sector. Access to oxygen therapy, as I said earlier, was a vital challenge. The private donor established oxygen plants for refilling. So these initiatives, in fact, saved many lives. Next, please. Hotels, stadiums, schools, monasteries, and other public buildings were repurposed into the quarantine centers. So in fact, these were multi-stakeholders, multi-sectorial collaborations. And as you see them on the graph, the country managed to establish and scale up to over 10,000 quarantine facilities within a short time. Next, please. So civil society, they also contributed a lot. The local organization, charity groups, they trained, recruited, and deployed the volunteers who play a very important role in many walks, as you see them on the screen. Next, please. Yes. So finally, the volunteers in local communities, they play a very important role in organizing the community-based prevention activities, resource mobilization, and support activities at the local level. So what did we learn from this experience? We learned a lot, but I'm going to share with you 3 key experiences. Next, please. Yes. So functional issues, understanding of the functional issue of the health system is always not enough. Click. We need to know about the population it serves. To know about the population, the health issue, and social suffering, it is important to know about the structural violence affecting them. For that, we need to know about the context. To know about the context, biosocial analysis is the key. Next slide, please. The second point was that the health system performance is not just the sole work of the public sector. It is a multi-stakeholder endeavor. And of course, the effective coordination and collaboration among those stakeholders is the key. Yes, next, please. The last one is the community-centered approach is the key to overcome the crisis that involve 4 pillars: community mobilization, participation, engagement, and resilience. Next, please. So before I close my section, I'm going to tell you quickly about the harm reduction program I'm currently engaged into. So yes, click please. So as you know, the harm reduction is not just about the healthcare or prevention of diseases. It is a lot more than that. It is about policies, concepts, practices, and access to services that would prevent or mitigate the harms of structural violence. Yes, you click. So it's a lot. Next slide, please. So now I'm running the harm reduction programs for those engaged into sex work and the drug use, people who inject drugs and people who use stimulants. As you know, those communities are facing a lot of social stigma, discrimination, marginalization, and misjudgment. They suffer most from the structural violence. Nothing about us without us. That is what they often say. So my learnings from the GHD program have helped me a lot to work with those communities and to equip me with the biosocial lens to understand what the needs are and how we can help them prevent from diseases like the HIV, hepatitis, and also to mitigate the impact of legal, physical, and psychosocial harm they are facing in their daily lives. So I think that's the end of my presentation, and thanks a lot to everyone. Over to you, Christina. Thanks a lot.
Thank you very much, Zarni. And so next we have Evrard. And Evrard, do you want to share your slides or do you want me to share them?
If you can play the slide, that would be great.
Okay, I will get them right up. Just a second. I have to do that. And then
while you're doing that, Christina, just, thank you so much, Zarni. That was great. And how wonderful to see you take your learnings from one place and start to apply them in another and take a very macro view, as you did also with your thesis, and then look at really individual patients and the very vulnerable. So I think it just shows the level of flexibility that you have as an implementer, but also that you've gained in looking at the re-socializing disciplines. And just for those who are tuning in, that was something that Paul Farmer was very fond of talking about, the re-socializing disciplines, which means to seat the work we're doing in re-socialize them by looking at history, looking at political economy, and not looking at them in the present day only, but all of the milieu of social science that we can bring to bear on our understanding. So over to you, Evrard, going from your amazing work in Rwanda to now Sierra Leone.
Thank you, Joya. Hi, everyone. It's such a pleasure. I'm so happy to be here and share my experience, but also congratulations to everybody. 10th anniversary. It's a big milestone for the faculty, for the alumni, for the future generation, for all of us to. There's a lot to celebrate. But I wanted. Before I started, I just want to say that I'm so fortunate. I'm so grateful to be surrounded with colleagues, friends, faculty members, and I feel like this program brings together people with almost the same how can I say spirit and energy around social justice, around providing health for all. And so, just want to really express that my expression to everybody, to colleagues, friends, faculty, Joya, Christina, all my colleagues. It's such a joy. I'll talk about the Sierra Leone Quality Essential Health Services and System Support Project that I'm currently leading in Sierra Leone. This is a project that we are implementing in Sierra Leone together with the government of Sierra Leone, partners in health, with the support of World Bank. Next. I wanted first to give a context of Sierra Leone in regard to maternal and child mortality. So Sierra Leone has suffered a lot over the past century, but over the past decades, the existing weak health system was affected by events like Ebola, the COVID-19, climate change, and Sierra Leone faced maternal mortality across the world. We are talking about 700 to 1,000 live births. And if you look at the past decades, the decrease or the gains in maternity were affected. The question is, how do we tackle that? But not just looking at maternal mortality or child mortality, but how do we think about horizontal strong system that will not only decrease maternal mortality, but also support the system broadly. The other thing is, if you look at most of the programs in Sierra Leone, they are mainly funded by external donors, and there is little coordination and coordination at the national level. So there's a huge need to bring funders, donors, partners together around one vision. The government is doing that. We're PIH, we are supporting that. But it's a journey. It's a journey. Next. So what is QSEP? So QSEP comes with this project with about $60 million from World Bank and GFF to actually provide a good platform for mothers, children to access high quality services. The government and World Bank and PIH, they wanted to start with a few districts, many high burden districts. And it's a 5 years project, as I mentioned. And PIH was, selected to be one of the implementing partners together with the Ministry of Health. We are really fortunate to use some of our experience globally, but also our experience in Kono, in one of the districts, where PIH has been working over the past almost 10 years to really influence that and effectively implement the project. Next. So this is just a map to show the coverage of the QSEP project. It's 5 districts with almost 3 million people. So Sierra Leone.
Did we, Evrard, at your, I don't know if we lost Evrard.
Can you hear me?
Oh, no, Evrard.
I can hear him. I can hear him. Yeah.
Okay.
Keep going.
Yeah, I was saying QSEP will cover 5 districts for about 3 million people. So Sierra Leone total has about 7 million people. So it's about almost a half of the population. And so Kono is one of the districts where PIH has been working over the past almost 10 years. And so we want to leverage the experience from PIH in Kono to effectively implement in other districts. Next. So the model is like a network of health facilities, small community health facilities, but also community health workers, and together with the teaching hospitals. So we want to make sure that there is a clear referral pathways, there is a clear communication between facilities, there's a clear collaboration between community health workers, facilities, community members, as well as the referral and teaching hospitals. Basically, think about the whole ecosystem of healthcare providers. Next. So this is a unique opportunity for PIH, for the government of Sierra Leone, to use the 5S model: staff, personnel, staff equipment, space, systems, social support. This is almost like the first time World Bank sort of accept to really adopt that system to build a horizontal health system. It's a huge opportunity. I will talk about that. But for us to have such multilateral funding mechanism, to have that wording, that language, that model as the main approach, it's a huge win for global health community, for PIH, to really use this model. Next. Next.
Now we see you again.
Christina, we can see Evrard, but I think you're not seeing Evrard.
No, I see him now.
Okay.
Yeah. Can you go to the next slide?
Next slide.
Yeah, sorry. I must be cutting out a little bit too, but
yeah,
sorry.
it's you. I don't think it's Evrard. Yeah.
Okay.
Good. So I'm sure many of you, almost all, are familiar with 5S approach. We want to think about the whole ecosystem of health system, not just one component, not just recruiting staff, not just like providing equipment, not just like think about supply chain system. We want to have this comprehensive approach with all the key components with the 5S, and we will use that during the implementation. Next. So this is just an example of one of the key activities or support that we provide in Kailaon district, one of the 5 districts. We'll recruit about 87 clinical and support staff. Those include CHOs, doctors, nurses, midwives, and we will train them and we'll provide keywise support and mentorship. We'll provide, of course, equipment, drugs, supplies, and we will make sure that we are working with existing system when it comes to supply chain, to make sure that we have a comprehensive maintenance plan to repair those equipment, troubleshooting whatever issues that may come up with those equipment. I mean, it's trying to be comprehensive when it comes to the support. Next. So some reflections. I'm sure there's a lot, but I just want to mention that this is a huge opportunity to build and strengthen horizontal health system with the particular focus of sexual, reproductive, maternal, newborn, child, adolescent health, both at the primary health level, but also at the central level. You know, in the past, I mean, even now, we still have World Bank and other partners who still have that like vertical approach, who how can I say, continue to use some of the weaknesses in the system to not provide comprehensive support. So for World Bank, for the Ministry of Health, for the government of Sierra Leone, for PIH to be able to have such a big grant and build a system with that, the 5S, it's a huge win. It's a huge opportunity for us to influence. Number two, it's a huge opportunity for me. I'm so grateful, I'm so humble to lead such a big project, also for my colleagues. Most importantly, as Joya mentioned, how do we end the project? How do we ethnography, history, political economy, how do we think about unintended consequences of this project to adapt and make sure that we are not leaving anyone behind? I'll give one example. This project is focusing on maternal newborn child. What about NCD? What about mental health? We don't want just to have a facility where we support mothers, newborn child, and when a 60 years old with injury shows up and receive no care. No. How do we think about those unintended consequences? How do we sit with World Bank, with the government of Sierra Leone to adapt as we go and include those other aspects? Number three, it's a huge opportunity, of course, for us to tap into a big MMSc alumni, faculty members, and other global health champions for feedback, for experience and learning opportunities. I'm so happy. I can, for me, this is a good opportunity to implement or experience whatever theories I've heard, I've learned from MMSc, and have implement that. And so it comes with humility, but also a lot of opportunity for me to be able to apply that. So I will stop here. I'm sure there's a lot to reflect on, but I look forward to hear your comment and questions. Thank you. I'll pass over to Christine again.
Yeah, thank you so much, Evrard. Amazing. Again, thinking of the work you did, which was very, very focused on newborn health, maternal newborn health in your thesis, going from that to being involved in large-scale strategy, sort of not unlike Zarni's kind of toggling back and forth between direct implementation and large-scale policy. Great to know that both of you are out there with those just really, really diverse skill sets. And we'll hear more about that project. And there's a great question that we'll get to about, the challenges in West Africa. And as a Rwandan working in a successful implementation health system, and the challenges, you see in West Africa, but we'll get to that next to the wonderful Jafet, Dr. Jafet Arrieta.
Thank you so much, Joya, and good morning, good afternoon, good evening, everyone. It's an honor to see so many familiar faces and names in the participants list, and to be here celebrating the 10th anniversary of a program that if I had to describe in one word, I would say is transformational at all levels. And I'm going to try not to be super repetitive to make sure we have time for questions, but I couldn't help it but to start with quoting our dear Paul Farmer, who I think inspired many of us, if not all of us, to do the work that we do. And this is one of the many quotes, right? But I think one of the premises behind what I'm going to share today is that healthcare is a human right. Is a human right and should be seen, understood, and acted upon as a human right here in the US, in rural Mexico, in rural Peru, and in China, and everywhere we are. And so the question for you, I'm going to try to make this also interactive. I'm going to invite people in the chat to share some of the reflections, right? Like who is considered human enough to have that right? Tell us. And then while you share your perspectives, I'm going to start with the story that brought me to the program, that brought me to the MMSc. Wow, it's hard to believe, but that was 10 years ago. And there are many stories, but these are the stories of a mom and a son. But this is also the story of a community and the story of our society. This is the story of Maria on the left and Jose on the right. Two people that I came across while working with Partners in Health in rural Chiapas. When I first joined Partners in Health to launch operations in rural Chiapas, my Chiapas is in Mexico, that's my home country. Back in 2012, I thought I knew what I was doing. I thought we were prepared. I thought we had the tools that we needed to provide care for people with chronic diseases, with tuberculosis, with HIV and other conditions. And then we found Maria and Jose. Maria had been seeking care for depression for over 20 years, for symptoms of depression which had been diagnosed as many other things except depression. And Maria is the mother of Jose, who she will describe to us as his crazy son. Jose has clinical schizophrenia, which had also been underdiagnosed and untreated. And please, I share these photos and I don't do it lightly. I know that they might, especially the photo of Jose, I know that it might cause some of you discomfort. And I hope it does. Because if it doesn't, I think that's what's brought us here, right? The fact that so many people have been complacent. And the idea, as Paul will say, that some lives matter less than others, which is at the root of all that is wrong in the world, and which I think is what really, really encouraged Joya and Paul to launch this program, so that people like us who were not okay with what we were facing, who knew that more needed to be done at multiple levels, who like me knew that having this experience in rural Chiapas and doing everything in our power to provide access to care for Maria and for Jose was not enough. Because if we are to change the realities of many millions and billions of people in the world who are suffering, we need to do it. We need to work with systems. We need to strengthen systems. And so today, this is a story of Maria and Jose who brought me here. But then I'm going to tell you about, and this is actually the topic of my thesis. As part of my MMSc thesis, I was trying to better understand the experience of living with and seeking care for mental health disorders in rural Mexico. And that really helped me inform my thinking, not only in terms of how to provide better access and better quality of care for mental health disorders, but also for other conditions. And that my main realization from having gone through the program is that we really need to strengthen health systems. We really need to inform what we do at the health system level, at the macro level, by what's going on the ground, by that suffering, that unnecessary suffering that we witness every day and that we know is preventable. Just some numbers here. 8.6 million people die every year of preventable causes. And you could say that more people die because of lack of access. Yes, that's true. Lack of access contributes heavily. But even those who do get access to care are dying due to poor quality care. So we need to do more and we need to do better, because high quality health systems will prevent a minimum. I'm sure this is an underestimate, a minimum of 8.6 million deaths per year. So why high quality health systems? Please tell us in the chat if you can type and feel like doing it. What does quality mean to you? Because I think that quality is used very lightly. Quality means many things. And for Maria and Jose, I'm sure it means something different. It means, yes, accessing care, but it also means feeling better. It also means being able to be productive. Jose had been chained for years in his rural community because that was the only way the family could find to protect him and to protect the people around him when he became violent. So quality means many things. And I just want to name some of the most known, I think, dimensions of quality. However, quality is much more than this, because at the end of the day, quality is local. But I want to highlight the fact that there are many dimensions that we have focused on for many years. Safety, we have talked about effectiveness, about evidence-based care. We are talking a lot about efficiency. However, for Maria and Jose, timeliness was key. It took Maria 26 years to get the right diagnosis and to get proper care. That's not timely. And moreover, we're facing a huge equity issue. Equity and social justice. And we cannot talk about quality without equity, regardless of the indicator that you look at, regardless of the country. Here in the US, where I'm based right now, but also in some other high-income countries, if you stratify indicators, regardless of the indicator, the poorest are the ones that are suffering more. So we cannot talk about quality without equity. And so if we go back to some of the other dimensions, so this report that I was referencing before also shows that we're not only experiencing poor quality, but there is also poor technical quality, but also poor experience of care. Again, 1 in 3 patients reports poor user experience, lack of respect, insufficient time with providers, long waiting times, right? This is quality. If we look at effectiveness, healthcare providers perform less than half of key clinical actions for common conditions that we know how to treat, that we have the tools to treat. And this is not me blaming providers. This is a systems issue. And all of these numbers ultimately matter because they result in unquantifiable and preventable suffering, which cannot and should not perhaps be quantified, because it's really hard to put a number. However, one thing that we learn in the MMSc program is that you cannot show numbers without telling the stories, without highlighting the suffering, the lived experience of those people that are experiencing that preventable harm. And the reason why we're here today in this panel is because we know that this is structural violence. Zarni, thank you for touching on that, because I'm gonna be able to move forward more quickly, right? Because we know that what we are seeing now, Paul will define as being the result of the way in which political and economic forces are organized and structured. And we know that if we are seeing those results, it's because our systems are designed to get those results. So we know how to do a lot of this. PIH has shown us the way, as have done some other organizations. And yet we continue to see a huge no-do gap, right? So that's not to depress all of you. That's to say there is a huge sense of urgency, but there is also an opportunity, right? If we look at WHO and the SDGs, they will say that UHC is a mechanism to achieve SDG number 3. However, as Tedros would remind us, UHC, universal health coverage, without equity is an empty promise. It's an empty promise, and yet governments continue to claim that they have reached universal health coverage as if that was enough. So if we are truly to change outcomes, to change the stories of Maria, of Jose, of communities at large, we need to redesign systems and remind ourselves that health systems are for people. And we need to go back to thinking about who those health systems are for and what are their core functions. Because a high quality health system requires to make sure that we are consistently delivering care. Joya reminded us at the beginning, this is about making care right and making health a human right, truly a human right, right? And making sure that a high quality is responding constantly to the changing needs of the population. So there are multiple frameworks. I'm just going to wrap up to make sure there is room for questions. But so this has informed my thinking. And now at IHI, I carry all of the tools that I learned during the program, but also during my work at Partners in Health. And I have been borrowing what works from different approaches. There are many frameworks and many approaches. And one of my friends will say, all of the frameworks are wrong. Some are helpful, right? So regardless of the framework that you use, I think there are many out there that are helpful. I think it's important to make sure that instead of competing, we come together as a community and unite our efforts towards a common goal. And so one of the examples that I want to share just from my work before I pause is this idea of approaching quality using a holistic view. Approaching quality and working at the systems level to strengthen health systems, to embed quality into health systems from a quality planning, quality improvement, and quality control perspective, making sure that once we improve outcomes, we also set up the structures, the infrastructure, the processes that need to be present to make sure that those outcomes are sustained over time. We have done a lot of this across many countries. I've had the privilege of leading a lot of this work. And working at the national, subnational, and health facilities level, right? At IHI, we are working with different governments from different regions across the world to develop national quality, to develop and implement national quality policies and strategies, building partnerships. Because at the end of the day, global health is local. And it's important to think about what quality means for the locals and also how they can operationalize it. We're working at the subnational level, supporting secretaries of health. We're working, training a ton of people on the science of improvement, but also adaptive management. And we are also working across many healthcare facilities. And I'm just gonna show you some examples from our work in Ghana, Ethiopia, Brazil. Right now, I'm leading a multi-country effort in Latin America alongside many wonderful people to improve outcomes for pediatric cancer. So I think my last message is that this is possible. We can improve outcomes. Just zooming in. Here you can see some of the work that we're doing in Ethiopia, where we are working at all levels, right? To improve maternal health, to improve neonatal health, but also to improve the experience of care and to do it in a sustainable way, in a way that really strengthens the local system so that these outcomes can be sustained over time. And I'm just gonna come full circle and mention that while we are doing all of this, we should never forget, because these numbers are big, right? And I could talk more about these specific interventions, but I'm just gonna come back to the story of Mateo, because if we manage to strengthen health systems, we're also going to be able to make sure that people like Maria and like Jose can live happy and productive lives. So with that, thank you. And I'm going to pause there. Christina, I know we're almost at time.
Yeah. Thank you so much, Jafet. That was, great presentation. Again, going from the really micro to the macro and everything in between. There's one question so far in the chat, but I want to start by asking all of you kind of to take off on what all of you touched on in some ways is harm reduction, right? Because the current system in the world just causes so much harm. I mean, structural violence is a force of harm. And, someone was asking me one time, do you think you work towards social justice? And I had to really reflect. And I thought, what we do in a lot of ways is harm reduction. Because when we see just these powerful forces, causing harm, whether it's a coup d'etat, right? And, or whether it's, this really destroyed system from a long war in Sierra Leone, or, just untreated mental illness. So maybe starting with Zarni, I'll have the three of you just briefly reflect on sort of how you see your work today in the past as sort of part of a harm reduction against structural violence.
There's a lot to it. Indeed, when we talk about the health systems, finally, what it serves is the population and the individuals, right? So the harm reduction is not just for the health and the social issues. It could be the political, it could be economic, and it could be legal and physical harms. So what we are trying to is the health system is trying not to deliver the health services to prevent or cure the diseases, but also to give the comprehensive approach that will, what Jafet means, quality, right? The quality of life, quality to be a human being. And so we are looking into not about the population, but about the individuals that is composed of the population, right? So the harm reduction indeed covers a lot of arenas, but that is what we call the comprehensiveness, the quality.
Thank you, Zarni. It's very clear. Evrard, how does the thought of harm reduction affect your work? Yeah.
Yes. It's a good question. So, I mean, Sierra Leone. I'll talk about Sierra Leone, the context where I am currently. The country has suffered a lot over the past, centuries, and when we think about harm reduction, it's also about think about those like mothers, those Sierra Leonean in rural area. Something we can do to prevent what we can call stupid death, and provide quality care. And when Jafet talk about quality care, for me, the simple way to look into that is, when I think about quality care, for example, in one of the districts, it's about if myself, one of my relatives, goes to seek care to that facility, am I going to be comfortable? Let's put ourselves in the shoes of the people in the rural area. Let's provide the type of care that we would expect for our relatives, the type of care we would expect for ourselves. When we're talking about safe space, let's provide a safe environment, a safe, dignified maternal maternity unit where my wife or any of my friend can go and feel comfortable actually to deliver or to have care. So I can see how, of course, again, QSEP is a huge opportunity to reduce harm as we increase the number of people who have access to quality care. That's where the other aspect, of course, I can see how, by working together with our colleagues at the Ministry of Health, World Bank, bring this notion of social justice, bring this notion of quality care, bring this in our discussion. We are not talking about the implementation at ground, but during meetings, let's try to push them to reflect on that, to reflect on, what would you do if one of your relatives will go to seek care in one of the facilities that we are trying to support, and make sure that the folks in World Bank, in Ministry of Health can reflect on that. That's our role. We need to push them to think about social justice, to think about empathy, to think about what would, if they're the one really to choose and do something, what kind of care would you do? What kind of support they should provide? Beyond these like theories and frameworks, but push them to reflect on that.
Great. Thank you, Evrard. Jafet, and then we have a couple of questions in the chat.
Okay, let me try to keep it brief. Harm reduction. I love this concept because at the end of the day, I was talking about suffering, and I think harm is a very well understood term, joyous. So perhaps we can bring back the discourse, right, to talking about not only showing these numbers and these huge quality and equity gaps, right, but talking about the fact that they result in harm and suffering for people and communities, and speak about harm reduction and about, I think that has really informed my work in many ways. I hadn't seen it that way, but I think it's important to, or I guess my invitation and perhaps provocation to all of us here today is to think about what we can do individually and collectively today, not tomorrow, to reduce harm for the people around us. Because I guess a key aspect of my message was that we strengthen health systems bottom up and top down. We cannot wait for the Ministry of Health to take responsibility and do the work. Yes, they should do that, and we should hold them accountable. And there is a lot that we can do today from where we are, from where we sit, to reduce harm and to reduce suffering.
Great. Thank you. Thanks, all of you. And there was a sort of a follow-up question that I'll just sort of answer live, and then we'll go to the other two, which was, also how do we think about harm prevention? And, a lot of harm prevention, I think in the cases we're working on, is alleviating the overall poverty, the overarching chaos, and health systems play a role in that, but it's not only that. I will take the two questions together. One is from John Sarbo, who says, even before the pandemic, countries like Liberia are struggling with 80% funding out of pocket. How does this contribute to the health crisis? Is this a public sector problem? And how can the community help? And I'm going to put the other question out to you too, because it's in a way related. And this comes from Dr. Auguste in Haiti, who's an incoming student, I'm happy to say. And she, writing from Haiti, said, what is the approach to strengthen the health system when a country is dealing with political instability and corruption? And I think all three of you have had that experience. Evrard most recently in Sierra Leone, Zarni, of course, in his home country of Myanmar, and Jafet, particularly working in Ethiopia in the middle of this crisis. So thinking about the out-of-pocket expenditure and also this sort of political instability, how do we think about health systems, which are really institutions, in that setting? So I'll go first to you, Jafet.
Oh, thank you, Joya. Well, that's I was just going to reply to Mary in the chat. It's not easy. It's not easy, and we should not claim that there is a single approach. I don't think there is one. And I think it goes back to this idea of when there is political instability, when there is a lot of corruption, and when the corruption spreads across the system, I think you need to start locally, engaging with people, going back to the values, right? Because at the end of the day, the work that we do is around values and about caring and about people. And I think understanding and highlighting how that corruption harms people, right? And naming it, using our collective voices to name that, to make it visible, I think is one step. While at the same time, currently we are working in Colombia at the micro, meso, macro level, as well as in Ecuador, where, as you may know, there's been some political transitions similar in Ethiopia. And I think we keep doing our work. We don't say, okay, we're gonna wait until there is political stability, because that might not happen anytime soon. And I think that ultimately, by keeping on going and doing our work and demonstrating what's possible, not because it's not because it's easy, because it's not, right? I do hope that ultimately we can change those upstream structures. I've seen that in different countries. I think in many other countries, there's still a lot more to do. And I guess my invitation in terms of an approach will be to, if you are doing health system strengthening work, to really try to understand the political economy forces that might be behind the political instability and the corruption that we see every day. Because I think it's going to take engaging with not only governments, but as Evrard was saying, with funders, multilaterals, right? And calling these out and making a call, making these visible, and again, highlighting how action and inaction leads to human suffering.
Yeah, thanks, Jafet. Zarni, over to you, because you've really had to deal with so much of this. So your very thesis was interrupted by political violence, and it's been ongoing. So how do you make sense of this? And also add in, I think, please, this out-of-pocket thing. How does that sort of progressive impoverishment of people contribute to our ability to strengthen the health system?
Right. So the out-of-pocket payment in Myanmar was relatively high as compared to the countries in the region. And when we think about all of the socioeconomic consequences that followed the pandemic, the coup, and other situations, that is a lot on the people, especially across all segments of the population. Of course, who suffered the most? The people in the lower segment of the population suffered most. But what is really important is, I always believe in the power of being a human. The human are very capable beings on the planet, right? Because to me, at the end of the day, what matters is the solidarity of the people, the resilience of the people. How it was so amazing in my case in Myanmar, how people mobilized the resources, even though, of course, it did not address all the needs of the health system and the gaps in the healthcare delivery, but it saved many lives. It helped a lot of people when the main public sector and all the pillars of the health systems are being collapsed. So the role of the community, the role of the people and the population is so powerful in this scenario, and we should never underestimate them.
Yep. Thank you. I think that's such an important thing, the resilience and the participation of community. When we think about human rights, we have to think about both sides. And, when I say both sides, I mean the government respecting, protecting, and fulfilling rights, and civil society's active participation. And so I think one of the most important things that civil society can do is hold governments accountable when they are, but that can be very hard in repressive regimes. And so some of the, we had one of our colleagues also, who I believe is on the phone, write about, how many doctors were involved in protesting the military coup in Myanmar. And so often we have to stand up for our patients, and that can actually be dangerous and easy for me to say in a country where I have pretty much freedom. But many of our students have not been from places like that. Evrard, turning it over to you, how do you think about, why don't you take the question that's more on the West African side? How does this out-of-pocket expenditure play a role? And you've seen in Rwanda where there's much more social protection, and Sierra Leone where there's very little. So how do you think about that and health systems?
Yeah, thank you, Joya, and John and Marie-Claire, Auguste, they raised an important question. Let me frame it in this way. I believe we need systems, we need strong system to change that out-pocket expenditure, but systems are also made by people, by individuals, by political leaders. We may think we are limited to influence because who is leading, who is taking that decision at the high level. But at the same time, I do think we need to do our best where we are. And how do we do that? Think about champions for any system, for any weak system, for any mess. If you think about Haiti, if you think about Myanmar, if you think about Sierra Leone, yes, we might be very disappointed about how things are run at the political level, but at the same time, we need to put things in context, to think about history, but identify champions, identify people within the system who understand those challenges and work with them. We've seen that. I mean, in Rwanda, here in Sierra Leone, you might be disappointed, but if you go to the Ministry of Health, you find some few people who are very conscious about that, who despite the challenges at the system level, they really fight. So how do we work with them? How do we work with them? How do we engage them? How do we work to actually reach even other people who can influence? So think about champions for me is one way. It's one way, of course, but it's one way we can sort of influence systems.
Yeah. And I think that that addresses so much of the governmentality side. Is if we think of government as a monolith, we'll never win, right? Because there's always actors that are corrupt. But, speaking from, my long experience in Haiti, as crazy as the situation can be and difficult, there are some really good people in the health sector. And so we've been able to, despite, many years of struggle, have really good technical people who care on the health side. Now, that doesn't fix everything, but at least it gives you the hope that you can, as we say in Haiti, as long as you still have a head, you have hope of putting on a hat. So I think that's the thing, looking for those allies at every level. And sometimes it's a community leader, sometimes it's a district health authority, sometimes it's the actual president itself. And Martha, hi Martha, she says, sounds like we need to tap into social capital, which I think is a great way to summarize. Somebody had asked, I think it was also Marta, what do you see? And she asked specifically with Jafet, so I'll start with you, but I think question for all of you. When you look at change, how do you see a time frame for health system strengthening? I think I've been fortunate to be working with the same organization for nearly a quarter of a century, so it's easy for me to see progressive change. But how do you look at it? How do you look at time frame for health system strengthening? So Jafet, and then Zarni, and then Evrard.
Thank you, Joya, and thank you, Martha. I would say it's a continuous process, and the amount of time it takes varies depending on where systems are starting on their quality journey. And also, we cannot deny the many structural challenges, which are also different in different countries, right? Of course, it will take longer in a failed state, in countries that are experiencing war, than in countries where there is more political stability. So let me name that because I don't want to make any generalizations. In what I've seen, at least because you can also think about change at the subnational level and the national level. I think that ultimately, if you start at the subnational level, even at the micro level, I know there's many critiques that sometimes we do pilotitis and just focus on the micro, but I think that ultimately that really changes the way the governments and the national health systems think and act. So I would say in 10 to 20 years, you can see measurable change. In 2 to 3 years, because I've seen it, you can also see change. Right now, we're running a multi-country collaborative aimed at improving outcomes for children with cancer in countries where the 5-year survival is 30% compared to an 80% 5-year survival in high-income countries. And we've seen many changes happen in terms of outcomes in just 2 to 3 years. And also, we're seeing how, as a result of those programs and those projects, that it's actually frontline providers and unit leaders and directors of hospitals who are committing to doing things instead of waiting for the government to say, hey, there is a national program for pediatric cancer, are doing, and how that is now informing policymaking. We're seeing that in Mexico, we're seeing that in some other countries. So it takes time, but it takes doing. It takes demonstrating what's possible, which I think is what also Partners in Health has done across many countries. And it's not easy, but I guess the key for me, the key message for me, Martha, is making sure that there is a long-term goal, and also short-term goals, but also consistency of purpose. I'm gonna pause there. Yeah.
Great. Zarni.
Yes, so first I agree with Jafet that, the health system strengthening, the timeline that we could see is varied, right? So I will bring in additional perspective, which is also important, is when we have make several investment in the country, in my case, to strengthen the health system. But what I realized at one point is it could be collapsed easily when we're talking about the context, which is a very fragile and volatile by the political pressures. By the health system itself, in my case, has been fragile, right? So what matters for this health system strengthening is not just about improving the performance and the efficiency of the health system, but also important the responsiveness and adaptability of the health system and the actors when the situation requires. So in my case, everything literally collapsed, and the ability of the health system to address the emerging critical issue, starting from the policy to the service delivery level, is how quickly they respond and adapt to the situation. In this case, which is like very much volatile, unpredictable, and without having any promise to make further progress. So for me, not just performance and the efficiency of the health system is important, the responsiveness and adaptability in the setting when the context is so fragile. And of course, the timeline, it's hard to predict in my case. Over.
Thank you, Zarni. And Evrard, I'd love to hear your take, maybe more from the Rwandan side, just because you have such a long experience there and have seen so much change. How do you think about the time frame for health system strengthening?
Yes, thank you, Joya. I see health system strengthening as a journey, but at the same time, with a visionary leaders, with leaders who are disciplined, who are oriented with equity, you can do miracles. I'll give you an example of Rwanda. Back 1994, Rwanda was a destroyed country. We had to start everything from scratch, from zero. But then it goes to, a destroyed country to a model in health system strengthening. Why? What are some of the reasons for that? There are, of course, yes, a lot of reasons, but one is about discipline for leaders who are leading the country. It's about leaders who are really think about equity. How do we provide care for everybody? Not only for a group of people, but for everybody. And then you saw the decline in child mortality in Rwanda in just like 15 years. That decline was like, has never been recorded anywhere, anytime. So yes, Rwanda still has to do a lot, but you can see when we think about time frame, what you can achieve in just like a small period of time, 10, 15 years is almost like, it's relatively short. So on one side, I'm very confident. I believe that it's possible. You can do a lot in that short period of time with disciplines, with the accountability of leaders. The other way is also possible. You can destroy everything in just a short period of time with political leaders and instability and political unrest. You can build a lot of health system, a strong health system, in just like 1, 2, 3 years down. I mean, one example is Libya. Libya during Gaddafi, it was a model in terms of care for all. And then, well, I don't want to go about, but with the influence of the West and then killing Gaddafi, everything down. So yes, it's a journey, but we can do a lot with strong leaders and champions and heroes. Yes.
Great, thank you. And I think there's a comment on empathy, and I think that might be a good place to end, because no matter what a system is, right, there has to be a human face, there has to be compassion. And how does that empathy and compassion sort of fit into health system strengthening, which is a boring and wonky term? How do you think about that? So I'll start with Jafet and then go to Evrard and end with Zarni.
Joya, thank you for that question. I think, if we think of compassion as a combination of empathy and action, right? When empathy leads to action and that creates compassion, I think, to me, that's what brought me here, right? I started with that story of empathy with Maria and Jose, with many communities, and that led me to the realization that I needed to do more. And I tried to remind myself every day of the importance of the work that we do and how ultimately both what we do and what we decide not to do affects people in one way or the other. And of the need to really, really be in proximity with the people that we work with, that we work for, and that we care about. I think that without empathy, we're lost. And I wonder, like, I think that's actually one of the missing ingredients for many of our leaders. For those people that talk about corruption and failed states and what we see across the world, I think at the heart of it is in part lack of empathy and compassion. So let's I try to remind myself of that every day, because ultimately we build the world one day at a time, and we all have to have work to do, because if it's not us, who? If it's not when? If it's not now, when? Right? And so we cannot wait.
Fantastic. Evrard, empathy in your work.
Joya, empathy and compassion. This is something every day I think about it. And I was discussing with a colleague here about this concept and how they applies in our daily work. And one thing I want to share, empathy is, again, that feeling to think about others when they're suffering, when they're in pain, when they're in trouble. That's good. That's very important. But compassion goes beyond just like feeling, but a desire to say, what can we do when we see some people suffering? So, Joya, I can see how when we think about global health, it's about delivery, it's about doing something. So with empathy and compassion, I can see how compassion is actually a response to respond to the empathy. Not just like, well, Haitians are suffering. Oh my goodness, that's very bad. But not just to do that. How can you go beyond? So now, what can I do? What can I do to help? What can I do to contribute to the work that is going on in Haiti? How can we support some organization like PIH? How can we support some champions who are fighting to restore hope? So empathy, good. Compassion, good, better. Response. Let's do something. Let's not be emotional. Emotional, yes, being emotional, it's one step, but let's do something about that. Let's not be, how can I say, I'm trying to find the right word, but not just like stay in your room or in a conversation, but do another step to respond to those people who are suffering, those people who are in pain, the people who are experiencing war. Ukraine, Haiti, Sierra Leone, everywhere. Let's do something. Let's do something.
Great. And Zarni, last word from you, my friend, and then we're going to wrap up.
Yes. So for me, the empathy, compassion, and the passion are really what drives the human being. In my case, the COVID-19, we know that, the health workers, not just my fellows in my home country, around the world, they're not just providers, they're also being affected by the pandemic, right? So we are being like the social distancing, lockdowns, and everywhere, the health workers, the health workforce, there's so much pressure and the burdens. In my personal case, there are a lot of hospital beds with food, and there is even no single room for the critical ill patients. So what we try to offer is the teleconsultations, right? So someone who couldn't come to the health centers had to stay home, and many health workers, my fellow doctors, offer the teleconsultation. But that is not amazing. What is more amazing was, I have two colleagues, close friends, who were just at that time lost their family members from COVID. And they were mourning, but they're just trying to keep delivering the teleconsultation during the time of the crisis. They didn't stop it, even though they were in the great sorrows and so they keep giving the teleconsultations, and they listen to the people how they suffer, the family problems, even though they themselves are in the sorrow and in grief. So being a human being, the power of empathy, the passion and the compassion was amazing.
Great. Thank you all so much. I mean, I think it's wonderful to end this series with this rich discussion by, three of our amazing graduates who are continue to do great things. We're so proud to be part of your story. And also just, I think it's inspiring to end a discussion on health system strengthening with compassion and empathy, because that's what keeps us human. And I think that's what keeps us positive. When we can see that one person's life is changed, that is health system strengthening too. Because if there's a person who's getting a treatment or a procedure or has access to care that didn't before, then we know that health system strengthening, at least for that one person, that one day is working, and that can be inspiring. And so, for all of you tuning in, to remember proximity to people who are suffering, and trying to bridge the gaps for even one individual is enough to change the world. So thank you all so much. I'll turn it over to Christina to close out, and Zarni, Jafet, Evrard, so wonderful to see you. Thank you so much.
Yes, thank you. Thank you, Joya, for moderating and as always for your leadership of this amazing program. Thank you, speakers, for joining us, and participants. This is a really lively discussion with everyone and a really great way to end our series, the 10th anniversary. Panels support celebrating the 10th anniversary. I do want to let people know we will have more alumni panels next year. This is not the end of alumni panels. This is just the closing of this series, and we will follow up with email to everyone who participated today to invite you to our thesis presentations next week and to future events. So once again, thank you so much, and we hope you all have a wonderful day.